Chapter 15, Anxiety and the Obsessive Compulsive Disorders. So anxiety is a normal response to stress, and it is a common human experience. Anxiety disorders are the most diagnosed psychiatric disorder in the U.S., with approximately 30% of adults reporting having anxiety disorder in the U.S. OCDs are a group of disorders that all have obsessive and compulsive characteristics, which can cause marked distress or humiliation. So anxiety is a universal human experience and is among the most basic of emotions. Anxiety is defined as feelings of worry, fear, or nervousness when stressed or threatened. Temporary anxiety can be motivational and protect a person from danger. So normal anxiety is a healthy reaction that is necessary for survival. Without anxiety, our ancestors would have had little motivation to run from the saber-toothed tiger or hunt the mastodon. Anxiety provides the energy needed to carry out the task involved in living and striving toward goals. Anxiety motivates people to make and survive change. It prompts constructive behaviors such as studying for an exam, being on time for a job interview, preparing for a presentation, and working toward a promotion. Anxiety becomes a disorder when it interferes with a person's ability to function and includes feelings of anxiety that occur at inappropriate times or situations, increase in frequency of anxiety, and duration becomes increasingly prolonged. Now, there are levels of anxiety. Mild anxiety is normal everyday worries and stress. A person experiencing a mild level of anxiety sees, hears, and grasps more information, and problem solving becomes more effective. Symptoms include restlessness, fidgeting, sweaty palms, and slight discomfort. For example, think about how you felt right before you clicked submit on that first drug calc exam. Moderate anxiety. As anxiety increases, the perceptual field narrows, and some details are excluded from observation. More focused and situational, with the inability to think about much else, the person focuses only on the situation right in front of them at that exact moment, and it usually subsides after the situation is over. Sympathetic nervous system symptoms begin to kick in at this level. The individual may experience tension, a pounding heart, increased pulse and respiratory rates, perspiration, and mild somatic symptoms. These can be like gastric discomfort, headache, urinary urgency. Voice tremors and shaking may be noticed. Mild or moderate anxiety levels can be constructive because anxiety may be a signal that something in the person's life needs attention or is dangerous. Symptoms include increased pulse and respiratory rate, perspiration, GI upset, and voice shaking. Severe anxiety impairs a person's ability to make decisions and even recognize their own needs. Symptoms do not go away easily. Learning and problem solving are not possible at this level, and the person may be dazed and confused. Behavior is automatic and aimed at reducing or relieving anxiety. Symptoms include those experienced in mild and moderate anxiety, but also include chest pain, vomiting, hyperventilation, erratic behavior, and even a sense of dread. Think about how you would feel if you got a phone call that a loved one had been hurt in a work accident. Panic is the most extreme level of anxiety, and it is the most disruptive and challenging. Someone in a state of panic is unable to process what is going on in the environment and may lose touch with reality. These people may become unable to move or speak and may run around shouting and pacing. They may also experience hallucinations. Acute panic may lead to exhaustion. Table 15.1 on page 270 gives you the levels of anxiety. Defenses against anxiety. Defense mechanisms are automatic approaches to dealing with stress that protect people from anxiety and help maintain self-image by blocking feelings, conflicts, and memories. Defense mechanisms happen all the time, but we may not be aware of them. Defense mechanisms can be healthy, so they're adaptive and help lower the anxiety level to an acceptable way, or they could be unhealthy or maladaptive, in which the mechanism is used to excess. Most defense mechanisms can be adaptive and maladaptive. Also, most defense mechanisms can be used in both healthy and unhealthy ways. Table 15.2 on page 571 is a very important table. So the clinical picture. Now we will discuss different types of anxiety disorders. We have specific phobias, social anxiety disorder, and agoraphobia. So specific phobias. These are uncontrollable, irrational, and persistent fears of a specific object, situation, or activity. Usually, these phobias are extreme enough to compromise an individual's daily functioning. Examples include heights, spiders, closed spaces, etc. Fear of blood, injury, and injections can be so severe that people avoid seeking necessary health care. Phobias compromise a person's daily functioning, and phobic people go to great lengths to avoid the feared object or situation. A phobic person may not be able to think about or visualize the object or situation without becoming severely anxious. The lives of people with phobias become more restricted as the phobic person gives up activities in order to avoid the phobic object. All too frequently, complications arise when sufferers try to decrease anxiety through self-medication with alcohol or drugs. Animals, the environment, and situation-specific phobias are more common in females. Having a first-degree relative with a specific phobia puts one at greater risk for having the same specific phobia. Few people are seen in healthcare settings for the treatment of phobias. In general, such individuals seek help for comorbid conditions, including major depressive disorder, anxiety, substance use, somatic symptom disorders, independent personality disorders. Table 15.4 on page 272 give the clinical names for common phobias, and I would be familiar. So social anxiety disorder is also called a social phobia. Is characterized by severe anxiety or fear provoked by exposure to a social or a performance situation that can be regulated negatively by others. Situations that trigger this distress include fear of saying something that sounds foolish in public, not being able to answer questions in a classroom, looking awkward while eating or drinking in public, and performing badly on stage. Whenever possible, people with social anxiety disorder avoid such situations. If they are unable to avoid them, they endure the situation with intense anxiety and emotional distress. Fear of public speaking is the most common manifestation of social anxiety disorder. Risk factors include ACEs, or mistreatment, as well as shyness. Risk factors for social anxiety disorder also include childhood mistreatment and those ACEs. The trait of shyness is also strongly heritable. Having patients who are shy carries a double risk of genetic transmission and parental modeling. Chronic social isolation may increase the risk for major depressive disorder. Substance use disorders are common and may be related to the social isolation and inhibition caused by this illness. Bipolar disorder and body dysmorphic disorder are also comorbid. In children, comorbidities include high-functioning autism and select mutism. Agoraphobia is experiencing marked fear and anxiety related to travel or location, which results in avoiding the situation. Agoraphobia refers to intense, excessive anxiety or fear about being in places or situations from which escape might be difficult or embarrassing, or where help might not be available. The feared places are avoided in an effort to control anxiety. Situations that are commonly avoided are being alone outside, being alone at home, traveling in a car, bus, or airplane, being on a bridge, and riding in an elevator. These situations may be seen as more tolerable with another person's company. Typically, agoraphobia begins in late adolescence or early adulthood. Examples include traveling in a car, bus, or airplane, or riding in an elevator, as previously stated. Can also include being at home alone. Agoraphobia can become disabling and cause individuals to miss out on possible enjoyable experiences. Panic disorder. The key feature are panic attacks, which are sudden and an intense wave of fear, discomfort, or a sense of losing control. The individual is not able to function, the perceptual field is severely limited, and misinterpretation of reality may occur. These people avoid situations, people, or events that may trigger an attack and worry that another attack will occur. People experiencing panic attacks may believe that they are losing their minds or having a heart attack. Typically, panic attacks come, quote, out of the blue. In other words, sudden and not necessarily in response to stress. And they are extremely intense. They last a matter of minutes and then they subside. It is important to rule out a physical cause first. In children and adolescents, attacks are unpredictable and substance use is common. Unpredictability is a key aspect of panic disorders in children and teens. The attacks of panic seem to come out of nowhere, last about 10 minutes, and then subside. During the attack, the young person is less able to articulate its psychological aspects, such as fear. Such individuals may become avoidant of situations where help is not available. They may develop feelings of hopelessness in controlling these attacks and may become depressed. Alcohol or substance use is common among adolescents in this disorder. On page 273 and 274, you can see the DSM-5 criteria. And then also on page 274, table 15.5 gives you an example care plan for panic disorders. People who experience these attacks begin to fear the fear. They become so preoccupied with the possibility of future episodes that they avoid what could be pleasurable and adaptive activities, experiences, and obligations. So separation anxiety disorder. Think about how an infant reacts when separated from the mother or primary caregiver. Separation anxiety is a normal part of the development and peaks around 18 months old and then begins to decline. However, separation anxiety disorder occurs when a patient has symptoms of extreme worry, sleep disturbances, nightmares, tantrums when the person leaves, GI upset, or headache. Most common anxiety disorders in children, it is one of the most common anxiety disorders in children and usually diagnosed by the age of 18, and it is more common in females. Adults often have impairments in social and occupational functioning and may have difficulty with romantic relationships. Environmental stresses such as significant loss through death of a relative or pet, separation from significant others, or a change in environment by moving or immigration can bring about symptoms of the disorder. A physical or sexual assault may also precede the symptoms. Generalized anxiety disorder is a persistent feeling of fear, worry, or being overwhelmed that lasts for months and it interferes with daily life. Excessive worry is your key for GAD. Children, teens, and adults may experience this worry, which is out of proportion to the true impact of events or situations. Common worries in generalized anxiety disorder are inadequacy in interpersonal relationships, job responsibilities, finances, and help to family members. Because of this worry, huge amounts of time are spent in preparing for activities. Putting things off and avoidance are key symptoms and may result in lateness or absence from school or employment and overall social isolation. Family members and friends are overtaxed as the person with this disorder seeks continual reassurance and about meaningless details. The individual spends a large amount of time preparing for activities and may put things off or avoid certain situations. Family members and friends become fatigued due to the need for constant reassurance. Sleep disturbance is a common symptom. Genetics, parental overprotection, and ACEs can be causes. Table 15.6 gives you a care plan for generalized anxiety disorder, and then your DSM-5 criteria is on page 276. So some other anxiety disorders include selective mutism. This is a severe anxiety disorder where a person is unable to speak in certain social situations. It usually starts in childhood and can persist into adulthood if it is left untreated. A condition where children do not speak owing to fears of negative responses or evaluations. They tend to speak at home around immediate family members, but when they are engaged in activities that do not require speech, these children will seem comfortable. Substance-induced anxiety disorder is diagnosed with panic attacks or other anxiety symptoms that are brought on by the use of or withdrawal from alcohol or other drugs, taking medications, or exposure to heavy metals or toxic substances. And then anxiety due to a medical condition. It is directly related to physiological conditions. You can see table 15.7 on 276 for a list of disorders that can cause anxiety-like symptoms. The individual symptoms of anxiety are a direct physiological result of a medical condition, such as hyperthyroidism, pulmonary embolism, or cardiac dysrhythmia. To determine whether the anxiety symptoms are due to a medical condition, a careful and comprehensive assessment of multiple factors is necessary. The first step in the nursing process here is to rule out physical cause by performing a thyroid function test, blood glucose level, echocardiogram, and toxicology screening. You need to determine the source of the anxiety, and you need to determine the current level of anxiety. There are assessment tools that can be used, which include the Fear Questionnaire for Phobias and the Panic Disorder Severity Scale for Panic Symptoms. Generalized anxiety as well as depression can be measured using the severity measure for generalized anxiety disorder, which is figure 15.2 on page 278. You also need to assess for potential harm. Hospitalization is usually not necessary unless the patient is experiencing suicidal ideations. You need to complete a psychosocial assessment, and you need to do a self-assessment. As the nurse, frustration with the patient can often surface due to the acknowledgement that the fear or anxiety is irrational, but being unable to control it. Change is often a slow process. Page 277 also gives you a self-assessment guideline. Make sure you're using therapeutic communication during your assessment and asking open-ended questions, because this will encourage the patient to talk. Nursing diagnoses and outcomes, anxiety and fear. So self-monitors intensity and uses reduction techniques, difficulty coping, identifies ineffective and effective patterns, asks for assistance and information, and they modify as needed. Impairs socialization and low self-esteem, self-monitors anxiety and desires for avoidance, uses techniques to reduce anxiety to maintain role performance. So your diagnoses are in bold and your outcomes are the bullets below them. You can see other examples on page 277 and page 279 in your book. And planning, patients do not usually require inpatient admission, again, unless there are some suicidal ideations. Planning will involve selecting community-based interventions. You need to encourage active participation in planning to increase positive outcomes. And patients experiencing severe levels may not be able to participate in planning at that time. Okay, so implementation. Interventions are built once the level of anxiety the patient experiences has been determined. And to help determine that, we sometimes need to help the patient learn techniques that promote relaxation like meditation. So if they're at a mild to moderate level, this patient will have the ability to make decisions and solve problems. But these skills decrease as the level of anxiety increases. So as a nurse, provide a calm presence, recognize the individual's stress, and be willing to actively listen. Page 280 Table 15.9 gives you some interventions for mild to moderate. Severe to panic levels, this patient may be out of control, is unable to make decisions, and does not know what is happening in the environment around them. Safety and provision of physical needs will be a priority. Table 1510. So counseling, it helps aid in communication and resolution of anxiety symptoms, as well as developing coping strategies. Help teaching and promotion. Many individuals delay seeking help for years, and then they reach out with a co-occurring problem. This is often due to physical symptoms. Education regarding recognizing triggers, their signs and symptoms, and coping strategies is very important. But make sure you provide this information in a calm manner and use simple language. If a patient is overly anxious, you may have to repeat the teaching several times. Teamwork and safety. Most patients are treated outpatient, but safety is considered if they're suicidal. And then again, promotion of self-care activities usually involve deficits in nutrition and fluid intake, personal hygiene and grooming, and sleep. Evaluation. Is the patient experiencing a reduced level of anxiety? Does the patient recognize symptoms as anxiety related? Does the patient continue to display signs and symptoms such as obsessions, compulsions, phobias, worrying, or other symptoms of anxiety disorders? If still present, are they more or less frequent and more and less intense? Is the patient able to use newly learned behaviors to manage their anxiety? Does the patient adequately perform self-care activities? Can the patient maintain satisfying interpersonal relations? And is the patient able to assume usual roles? So what level of anxiety could actually be a good thing on the day of a nursing exam? A, mild. So pharmacotherapy, antidepressants, they also treat depression, which is often a comorbid condition with anxiety. Your SSRIs, again, are a first-line treatment. But note that some SRIs may initially increase anxiety. SNRIs are sometimes used as well. But then there are anti-anxiety drugs like benzodiazepines. Remember that suffix for your benzos is PAM. Benzos are most commonly used due to their quick onset, but they should only be used for short periods of time. Side effects should be closely monitored, and benzos are contraindicated in those with a substance use disorder and with older adults. An important nursing intervention is to monitor for side effects of the benzos. This includes sedation, ataxia, and decreased cognitive function. They may also have paradoxical reactions, which are reactions that are the exact opposite of what the intended response is. Another option is Buspar. It does not cause dependence, but the onset of action, as we talked about earlier, are 2 to 4 weeks. Buspar can be used for long-term treatment, but it is not recommended for anyone with a hepatic or a renal impairment. Page 282, this table lists some of the drugs. Some other classes, there are other medications that can be used in conjunction with those listed previously on this table if they are ineffective. These include beta blockers, antihistamines, anticonvulsants, as well as antipsychotics. In children and adolescents, duloxetine is FDA approved for children ages 7 to 17 to treat generalized anxiety disorder, but other medications may be prescribed off-label. Integrative medicine. These are herbal therapies and dietary supplements. I'm not going to dig down into those. And then there are psychological therapies. You have behavioral therapy. And this comes with certain terms as you see here in the bullets. Modeling, so role modeling, you role model to demonstrate the appropriate and desired behavior. Systematic desensitization, this is when you gradually introduce an individual to the feared object or experience and you progress toward the most frightening. Flooding is a technique in behavior therapy in which the person is exposed directly to a maximum intensity, anxiety producing situation or stimulus. It's either described or it can be real without any attempt made to lessen or avoid anxiety or fear during the exposure. And then thought stopping describes the process of suppressing or pushing away unwanted thoughts and aims to disrupt negative thinking patterns and redirect thoughts to something that helps relieve distress. And finally, cognitive behavioral therapy is a type of psychotherapeutic treatment that helps people learn how to identify and change destructive or disturbing thought patterns that have a negative influence on behavior and emotions. It focuses on changing the automatic negative thoughts that can contribute to and worsen emotional difficulties, depression, and anxiety. So moving on to obsessive compulsive disorders, OCD. OCD is precipitated by anxiety and it can be diagnosed in children and adults. It can be mild to severe, but there are certain criteria for diagnosis. The patient must exhibit obsessions, compulsions, or both. So let's talk about what those are. Obsessions are persistent, recurrent thoughts or urges that are unwanted and become intrusive. Examples include thoughts about being harmed or harming someone else, fears for safety, concern for cleanliness or germs, fear that they are offending a higher power, fear of forgetting something important, and worry about how tidy or neatly items are arranged. Compulsions are repetitive behaviors that are performed by the individual to lessen or prevent anxiety brought on by their obsessions. Examples include checking and rechecking a door that is locked, ritualistic order for hand washing, repeating specific words or phrases, hurting yourself such as hair pulling, counting objects, items, or actions, and repeating an activity a specific number of times. For people with obsessions, for example, like with concerns about cleanliness, letting them clean may actually help some people lower that anxiety to a tolerable level. You need to understand that these people have difficulty relaxing. They are rule abiding and they have increased anxiety if rules are not followed. These people are aware of their compulsions, they are aware of their obsessions, and they are aware of their perfectionistic behavior. However, their anxiety can be worsened if they don't obtain these things. You can see criteria on page 284 in your DSM-5, and you can refer to table 1512 for common obsessions and compulsions. So what are some risk factors for OCD? Child abuse and trauma, so your ACEs, post-infectious autoimmune syndrome, genetics, a first-degree relative that has OCD doubles your risk, and a comorbidity with anxiety disorders, eating disorders, and or a tic disorder. So let's talk about some of the different OCDs. Body dysmorphic disorder. It is a persistent preoccupation with a perceived defect or flaw in appearance. They exhibit mirror checking, excessive grooming, skin picking, and they seek reassurance about their looks. They often fear rejection and are perfectionists. Suicide risk is high, and the disorder is often a result of an ACE, and they may develop an eating disorder. So you may need to assess their nutritional status. An example of a body dysmorphic disorder is they think they are too fat, or they think their nose is too big, or their big toe on their left foot is too small. Trichotillomania disorder is a hair pulling disorder That can be hair on the scalp, eyebrows, eyelashes, pubic area, limbs or axillae. Can also have trichophagia, which is chewing and swallowing the hair after it is pulled out. A hoarding disorder is an obsessive accumulation of objects that consumes a person's life. Unable to let go of items and usually are alienated as family and friends stop visiting. Home may become unsafe or uninhabitable. Stressful events usually precedes the hoarding. And then excoriation disorder. This is a skin picking disorder. It's usually the skin on the face, but it can also be on the head, cuticles of nails, backs, arms, legs, hands, and feet. And then there's other compulsive disorders that can be substance-induced or due to a medical condition. And you can see these in the bullets on page 286. So Anton comes to the behavioral health clinic asking for help. I know this sounds weird, he tells the nurse, but I have to carry tissues with me everywhere. If I don't have a pocket packet of tissues, even if I am late for work, I have to turn around and go back home. I mean, I was late for my own wedding rehearsal and dinner, and I thought my fiance was going to break up with me for that, but I had to have those tissues. When asked if he can expand on why he feels a need to carry tissues everywhere, Anton says, I need them to open doors and clean dishes when I don't eat at home. Whether it is a doorknob or a fork or dish in a restaurant, I swipe it like 3 times with 3 different tissues. 1, 2, 3, like that. I don't feel safe without doing that. Sometimes I don't have a tissue. I can barely stand to open a door. But that's not all. At work or in a meeting, if I sit down and don't swipe the desk or table 3 times, I feel like it's not going to go well. Anton's symptoms are most indicative of what disorder? D, obsessive compulsive disorder. So let's talk through the nursing process. Assessment, it may be hard to understand what the patient is experiencing with OCD, and it may become frustrating. Remember that these disorders are biologically based. In figure 15.3 gives you an OCD inventory tool that you can utilize during assessment. Nursing diagnosis, examples include anxiety, impaired skin integrity, disturbed body image, risk for self-destructive behavior, risk for impaired socialization. Your outcomes identification, you can see these bullets here: reduced anxiety, improved skin integrity, reduced self-destructive behavior, improved body image, improved socialization, reduced fear, improved coping, and improved self-esteem. Now, planning. Planning is patient-centered. These patients tend to be resistant to treatment, but help them understand how the behaviors are affecting their daily life. Remember, OCD is an anxiety disorder that is characterized by recurrent behavioral patterns that a patient feels driven to perform. Whether a physical or mental act, the aim is to neutralize their anxiety or distress. In the initial phase of treatment, the nurse needs to allow adequate time for the patient to perform rituals to help the client handle anxiety. The priority is caring for the patient, so it's helpful to identify any precipitating factors for their ritualistic behavior and utilize that when you're planning. Now, implementation is promotion of self-care activities, health teaching, administering medications as prescribed, and therapeutic communication. And finally, evaluation. Did the function improve and the distress and anxiety decrease? Treatment modalities. Again, you have your SSRIs. You have other drugs that have been approved. You have certain antipsychotics. But there are no drugs for body dysmorphic disorder, hoarding disorder, trichotillomania, or excoriation disorders. But you can use SSRIs to address the OCD parts of the symptoms. Surgical treatments are going to be reserved for severe symptoms. Gamma knife creates lesions to form a disconnect of those overactive circuits in the brain. It does not require opening the skull, but multiple gamma rays pass through the skull. About 60% of those that do not respond to behavior therapy or medications will get benefit from this procedure. There's also that deep brain stimulation that we've already mentioned before. This is an implanted pulse generator that uses a low dose of current to reduce symptoms. This procedure is reversible, and it is used for people who have failed at least 3 trials of SSRIs. Psychological therapies, these are going to be performed by an advanced practice healthcare provider, so not by a typical registered nurse. You have your exposure and response prevention. This is a first-line cognitive behavioral intervention for OCD. It exposes the patient to triggers of their symptoms, and the message you want them to receive is that anxiety will subside even when you don't let them complete the ritual. And then flooding, we've already talked about, exposes the patient to a large amount of trigger to extinguish their response. So a nurse observes a client who has OCD repeatedly applying, removing, and then reapplying makeup. The nurse identifies that repetitive behavior in a client who has OCD is due to which of the following underlying reasons? C. Attempt to reduce anxiety.